a little bit different. And I'm going to say it's unexpected too. I did not expect to announce for the first time to all y'all that I have uterine cancer. So we're just going to drop that bomb right off the bat. But the reason I'm leading with that is so that you understand the purpose of this episode. Since my diagnosis, and I've always been planning on releasing these episodes along with my deep dive of all the different rabbit holes I've been going down, just wasn't planning on doing it so soon. But what happened was my Dutch test came back, reached out to my dear friend and colleague, Betty Murray, and I said, okay, interpret this for me. And what do you have to say? And she came back with, well, you're going to be shocked and pissed. And I've uncovered a whole lot of shit. So that's why we are recording this soon. You are going to hear this very soon because I feel like this information is vital to get out there as soon as possible. So there's no marketing plan for me announcing to have cancer, that I have cancer. It just is. Here's what it is. Here's what I'm dealing with. And what I'm learning along the way of this journey is that it is so important for all of us, especially women, to know your risk. And even when you're going into bioidentical hormone replacement, and I'm going to talk to Betty about this, but my opinion is static dosing. Okay, you're pretty safe, but it's really a good idea to have a Dutch test and you go a little bit deeper and look into how you metabolize your hormones, maybe go down the genetic pathway as well. But especially if you're doing something like I was doing, which is the Wiley protocol, requiring higher doses of hormones, you know what? I'm going to die on this hill and say you damn well better know how you metabolize your hormones if you're putting those levels of hormones in your body. And I don't care that it matches the rhythm to what you used to do. You want to know how your body takes and metabolizes and deals with, detoxifies, processes, whatever name you want to give it, how it deals with those hormones. So that's what we're going to unpack today as it relates to me, because I got to tell you, after I go through the treatment and get the hysterectomy and do all the things, I want to go back on hormones that are exactly right for my body. No more guessing, no more throwing darts. I want to dial in the exact hormone protocol that is right for me. So, Betty, thank you so much for jumping on a Sunday to go through my Dutch test, to educate these people out there. I know you're going to be releasing this to your audience as well, because we're both passionate about women getting the help that they need and being educated themselves about their own body.
No, you're absolutely right. And I think, it hurts me that you're going through this. But I also have to look at it and go, there were two people that are probably the best people to go through this. You have a level head, you understand a lot about all of this and can take very sort of measured approach without running in fear, which is what most people do is they run in fear. And I think a couple things that I want to clarify while we're going through this conversation today is number one, bioidentical hormones are not really the cause of cancer, right? They
Right.
aren't.
Right.
But how you metabolize hormones and all of the estrogenic sort of materials out there, the xenoestrogens, can drive a risk whether you have hormones or not. My scientific argument is without hormones, we don't have our protective estradiol and estriol. We actually might be stimulating these pathways heavily with other crap from our environment, like
Mhm.
fragrances and phthalates and all that other stuff. And that's why we see these cancers more in a menopausal woman than we do in a 25-year-old. So, what we're going to walk through today is a couple of the major pathways that research is kind of pointing to. And just to give some people qualifications, like why am I uniquely qualified to have this conversation? I spent 3 years of a PhD immersed in hormone metabolites. I am one of the world's experts on how these move through the body, what they do, particularly in the gut and elsewhere. And we've been capturing this data in my clinic as long as we've been able to test for this. So well over 12 years. And so I have a unique perspective that we don't see in conventional care. We don't see from the Menopause Society. We don't see in any current treatment because there are major gaps in how we test for these things. And so I'm going to explain how I look at it and what we see. Because I don't want people to walk away and be, oh, I'm terrified of hormones.
Right.
It's more so you need hormones. and most people deserve and should have hormones, but we have to be educated on what we need to do hormones safely. And even if you're not doing hormones, it would be valuable to know these things because they also increase your risk for cancer, even if you don't have a damn hormone in your body.
Oh, yeah, absolutely. And yeah, let me clarify too. Every single conventional doctor I saw, including my oncologist, said, stop hormones immediately. And then they wanted to put me on a synthetic progestin, which made me laugh. I'm like, do you understand that I am on large amounts of bioidentical progesterone, right? So they wanted me to stop everything. I have not stopped everything. I've reduced my dose of estradiol, kept the progesterone high, and I'm basically riding out static therapy until the time of my surgery. And then we'll discuss probably on this show what I'm going to be doing afterwards. But I loved hormone. I mean, I do love hormones. I love currently and loved my higher doses of hormones. I felt amazing. So there's no way in hell I'm going to give them up. And to your point, oh my God, please do not anyone listen to this think that we are saying that hormones cause cancer. That is not the point. That is not the point at all. In fact, the hormones that I'm going to be putting back in my personalized, precise dosing regimen ultimately will protect me against cancer, because we know that about hormones as well, that they provide way more protection when done right and done in the right combinations and doses for our body.
Absolutely, absolutely. So are you okay with me like throwing your report up here and showing
Hell
everybody?
yeah.
You're like,
Yeah.
heck yeah. Let me
That's why we're doing it. Yeah.
that's why we're doing it. All right, let me scroll through here and I'm just gonna get the big picture up here and then I'm gonna share my screen.
So yeah,
All right.
this is my second Dutch test that I've ever done. In
Yeah.
comparing this one to the other one, very, very similar in the pathways that I push down.
Yeah, so I'm going to give a couple pieces of context here first, right? So tell me a little bit just to make sure that we're on the same page. So while you were on this test, so anybody that's never looked at this test before, these are speed dials, right? So these are speed dials that basically say if you're in the green, that means that you're in an expected level of physiological dose, particularly if you're on hormones, or if it's before you go on hormones, your physiological dose is appropriate. And then if it falls below on the left side, that means it's under physiological dose. And if it's in that little purple field, it's a postmenopausal range. And then if it's in the red over here, it's considerably higher than what's expected. And it's breaking down into basically your estrogens and your testosterone and your progesterones, right? So while you were on here, you were on rhythmic dosing. Is that correct?
When I did this test, which was literally done probably about 2 weeks ago, I had changed over. So the beginning of April was my diagnosis. At that point of time, I changed over to static dosing
Okay.
of 2.1 milligram patches twice a week.
Okay. Okay. All right. And then said you were inconsistent with your testosterone, but you had been doing testosterone kind of on and off, or at least some androgens, right?
Definitely. Yeah.
Okay.
About 10 milligrams a week of tescipionate plus the oxandrolone.
Okay. Okay. And then obviously you were doing physiological doses of progesterone.
Yes.
Right. Okay. So there's a couple things that stand out to me here, and I'm going to kind of walk through this, and I'm going to throw a bunch of other diagrams up. So first and foremost, obviously, if we look at your results and we look at your testosterone, it's incredibly low, right? And even DHEA is relatively low, and your other androgens, which are all in the little green area right here. And androgens are a recovery hormone. They rebalance things. They're protective against breast cancer in most cases. You do have a little bit of a preference for the 5-alpha reductase pathway, which I'm surprised because I know you don't lose hair a lot, even even though you do, right? But what's interesting to me is there's a huge gap in these tests, whether it's Dutch, HUMAP, the hormone Zoomer by Vibrant, any of the companies that do urinary hormone metabolites. There's a gap, and it's how the test gets run. Because you should have at least some testosterone. It might have been at the lower end of your dose or later on, right? But your testosterone it looks almost non-existent at 1.3, right?
Yeah.
Now, I'm going to point out a couple other things and I'm going to start wrapping this together. So the aromatase enzyme can take testosterone and make estradiol, and it also can take androstenedione and make it into estrone. Right. So, and if we look at your genetics, if we were just to look at your genetics, you have a high propensity for aromatase to make estrogens.
Mm-hmm.
Right. And we'll go back to that genetics in a few minutes, right? So that what that means is your androgens have a strong commitment to making estrogens, right? So if we look at your estrone, it's on the high side of normal. If we look at your estrone or your estradiol, it's very, very high. And then your estriol is relatively high. So there's some very important caveats here. First and foremost, estradiol can go back and forth between this 17 hydroxy steroid pathway and get made into estrone, right? So these two can get made back and forth to each other, and then aromatase also makes estrone. So if you are on testosterone, it doesn't make sense for it to be very, very low with a normal estrone and a relatively high estradiol. Now, when we look at how our body metabolizes estrogens and toxins, I'm going to use an example. So I'm going to use this. I think it's a lip balm. So when your body goes to prep this to get rid of it, genetically, it's going to move it from either estradiol, estrone, or estriol down one of these three pathways. So it's either going to go down the 2-hydroxy pathway, the 16-alpha hydroxy pathway, or the CYP1B1 pathway down to 4-hydroxyestrone. So I like to think of that. It's kind of like Goldilocks and the Three Little Bears. The first pathway is the porridge is just right. That's that green pathway. So it's going to wrap a wrapper around that estrogen molecule because it's got to get the green wrapper around it because it has to be done in order for it to get thrown out. So your preference for that 2-hydroxy pathway is pretty strong, right? It's pretty strong. Then let's look at the blue pathway. Like I like to consider that the sort of in between in the pathway. That's a blue wrapper. And that wrapper is made by the CYP3A4 pathway, which you have a slight preference for, which makes 16-hydroxy estrone and also makes estriol, which is a very weak estrogen, but becomes very important later on. And you genetically make quite a bit of estriol, right? But not a lot, right? And if we look at your little pie chart down here, there's a very low amount of basically estriol production. And then estradiol, which is our protective estrogen made by our ovaries that peters out when we're in menopause because the egg carton is empty, it no longer gets made. So when we put estradiol back, estradiol can go back and forth and make estrone, but it can also go down through these pathways. And then the last one is that CYP1B1 pathway. So this is the one most associated with cancer risk based on if you're looking at Dutch or HuMap or the Hormone Zoomer. All of those companies will point this one out because if you make a lot of that metabolite 4-hydroxy, it makes a metabolite that can damage DNA. And when you damage DNA, it creates spelling errors, and then you can get cells that don't realize they need to die, right? Apoptosis. So the 4-hydroxy pathway is considered damaging, and you make quite a bit of it. It's not your highest, but you make quite a bit of it. So where does the testosterone come in? All right. So all of these tests, because of the mechanism of how they perform these tests, have a huge gap. And basically what that gap is, whether they're using urinary hormone out of a tube or you're peeing on a strip and then you're using it later, in order for them to perform the action, it has to go through a thing called hydrolysis. When that happens, it destroys a sulfate bond. So one of the major pathways of estrogen and testosterone detox is no longer visible on any of these tests. Here's where it becomes important. So if the process of the test actually destroys the bond for the most primary way that estradiol and testosterone get detoxified, I have no real visibility to it. It is using a glucuronidation technology to see it. So here's the way to think about it. The very last step of detoxifying all of your hormones and basically most of the crap coming out of your body, honestly, it gets to, I like to describe this as, okay, I'm going to clean out my house. So I start in the attic, which is going to be up here in these very first steps, right? The CYP1A1, the 1B1, or 3A4. Okay, I'm going to get all that junk out of my attic, right? And so I drag it into the kitchen. That's step one. That's your phase 1 liver detoxification. None of that stuff is getting out of the body until it gets to phase 2. And phase 2 is where we do glucuronidation, we do methylation, and we also do sulfation, right? So phase 2 is getting it to the garage and the dumpster. So the
Okay.
challenge is because of the mechanisms in which they use this test, we see half of the distance of phase 2 and we never see if it makes it to the dumpster,
Okay.
right?
So
So
there's no test out there yet that can show us that. That's what
no, and
basically you want to develop.
yeah, exactly, exactly. So here's the thing. So I either have it wrapped in green, red, or blue, right? So your green is pretty heavily, promoted. Your blue's small, right? And your
Mhm.
red's relatively small. So if we were to look at this, we would say your estrogen metabolism pathway looks excellent, would we not?
We would. That's
We
true.
would,
Yes.
right? But the testosterone points to something that is awkward and odd. Because testosterone is almost always mostly sulfated, right? So it goes through the sulfation pathway, which is not visible. To have somebody taking testosterone with an absolutely low level of testosterone on a Dutch, an adequate level in the blood, is a sort of proxy for a sulfation problem because we can't
Okay.
see it on these tests,
Okay.
right?
Yeah.
Now, so I know this is like people are going to go, holy crap, what is she talking about? Right? It's hard, right? So we've got that very first step. We're upping the green, the red, or the blue wrapper, right? So if we get to the methylation down here, all right, so we get to the very bottom here, that methylation wrapper, everybody'd
Mhm.
say, oh my God, you're methylating great because you're taking methylfolate and B12 and B6 and B2, right? Think of that as the pink wrapper. Well,
Okay.
methylation isn't the final step. It either goes glucuronidation, which is estradiol's primary fate, or it goes sulfation, which is estrone's primary fate. Now, estrone is very, very important because estrone is pro inflammatory, right? We don't want a lot of that. And
Right.
estrone is what we make mostly when we go through menopause because our fat cells can make it. That's why we gain weight during menopause. And so, estrone, whether it's being made by our fat cells or aromatized by a testosterone or androstenedione, or being converted from estradiol, if it's estrone on its own, it's damaging, right? If it doesn't get
Mhm.
out of the body, it has to go through one more step called sulfation that has several other genes that are either good or bad. Does that kind of make sense?
Yeah.
Yeah.
No, that makes sense. While you're on before you go on with that, while you're on
Mhm.
that methylation activity, where does someone want that? Is it best to be that dial all the way to the red like it is with mine, or do you want it more halfway?
Here's the thing. I am of the mindset that we want to be in those ideal ranges and not really high because more is not necessarily better. I mean,
Right.
there is science seeing overly methylated vitamin utilization and like colon cancer risk increased.
Mhm.
And the reason is we've never ever been able to give super physiological dosing of vitamins until recently, right? It would never be seen in human experience. And so I think adequate and not too much and not too little is really, really important, which is why I'm such an advocate for testing, because then we can kind of stick with the science that we do know, right?
Yeah.
So I'm going to show another picture. This is actually from Genova. They do, I didn't really ask them, but I do use their picture quite a bit.
Mhm.
Um, because let's see, I'm going to show that. All right. All right. So if you can see this window, right? So again, this shows that diagram in a little bit of amplification. So here's where it becomes important. So your testosterone, again, it was really, really low. So that's your testosterone right over here. Yeah, hopefully you can see my little hand, right?
Yep. Uh-huh.
All right. So the 17 hydroxy pathway is right here and right here. Here's the first thing that I think is happening. You're aromatizing some of your androstenedione to estrone.
Mhm.
You've got plenty of estrogen. You had testosterone, but estrone isn't going to just get to 4-hydroxy, right? And it isn't just going to make it here. It has to get sent to sulfation, which is what we don't see. You look like you methylated quite a bit, but that's not the preferred pathway. And
Mhm.
glucuronidation through the gut is the preferred pathway for estradiol. So where this becomes more important is um, I'm going to flip to another one, is this final metabolism pathway that is actually controlled by a different, basically a different set of genes, right? And this is even hard because this is something I've talked with all the genetic companies too, right? So the reality is at the very end of that diagram. So imagine at the end of that hormone diagram, you've either methylated your estrogen or you've left 4-hydroxy hanging. Most of your estrone must get a sulfate bond on it. And it takes two major genes. One is called Suox, and Suox basically takes sulfites to sulfates, making them non-toxic. And we produce those in the body, and they're made from the cysteine pathway of amino acids. And so this is very, very dependent on, do you have sulfur donors, right? Sulfur donors. So Suox is the first step. And then the last gene is a gene called SULT1A1, SULT1A1. That is the gene responsible for testosterone and estrogen, and particularly estrone, going through the sulfate pathway, right? So it says, hey, I'm moving estrone, which is fat loving, to a water soluble form of estrone sulfate that then gets peed out, right? Does that make sense? So this
Yep.
is the last step that is not visible on any labs anywhere at all. And it makes me absolutely batshit crazy.
Yes.
You know,
Yes.
because I mean, I've been in conferences and held my hand up while they were doing a presentation about how wonderful these tests were. And I said, what happens when I have a blood level of 150 on a testosterone and I see a testosterone of 2? Because I know you use hydrolysis. So is my assumption that you cannot see sulfation. So if I see that, that's a proxy for a sulfate problem. They're like, well, yeah, maybe. I'm like, okay, thank you. Thank you. And a whole bunch of other people were like, what'd you just say? I was flabbergasted, because we take these tests and they are good and they are super helpful, but they are missing an entire gap here that may be really, really important. Right. And for somebody like yourself or somebody like me that has less than favorable pathways here, we're running under an assumption that everything's normal. And the reality is, I would say it's not great anyway. Right. Regardless of whether you do hormones or not. And if I were to show you my genetics, you would, you would see an even worse case scenario. This is the reason why I do what I do, because my genetics were so poor, right? Because we see here, like, your propensity for estrogen dominance. You're going to make a lot of estrone out of androstenedione.
Yep.
You're going to have more estrogen toxicity, you know, because you have an upregulation in some of those pathways and a downregulation in 2-hydroxy. Your COMT isn't bad. So COMT helps methylate basically the estrogen. Glutathione, not awesome. But the problem is we need SOLT. We need UGT here, which is the glucuronidase pathway, and we need the SOLT pathway to identify. Because my bet is, if we looked at your genetics and we were able to identify your SOLT pathway, you have mutations there.
Okay. Interesting. So now when you have, let me ask you this, is my profile and what you're seeing more on the rare side or more on the common side that
Common.
we need to, oh, okay. So what, practicality wise, what does a person do when they get their Dutch test back and they're seeing some not correlating with the blood markers? How do they know? How, like, or is this just a step that we are going to be missing until one of the companies steps up and listens to you?
Yeah. Yeah. So I extrapolate it from a bunch of different data, right? So I would say your genetics that we see here aren't necessarily radically off, right? You know, they're not. The likelihood of everybody having a green in all of those pathways is nil, right? Again, we have to remember that these pathways were not problematic. Methylation was not problematic until industrialization, right? When we started loading the environment with toxins.
Right.
So your body has a normal pathway here. So when I look at these and I see something like a free testosterone on a Dutch really low, despite knowing that they're on it, the first thing I do is I get a total and a free testosterone on blood, right?
Yeah.
To correlate. Because sometimes it could be the pharmacy screwing stuff up. I know you've seen that when I'm like, okay,
Yep.
you're on it, but there's nothing in it, right?
There's nothing in it. Right.
Right. The other thing I will do is I will have somebody run an estrone serum, right, which is going to show you the fat soluble form, and estrone sulfate, right?
Okay.
And what I remember, you and I were going back and forth yesterday, and the last time you had it done, what were your numbers?
So the estrone, not the estrone sulfate, the estrone alone, well, the high, it's always been high. So the last marker was 188. The one before that, I think it was in 2023, was a 409.
Yeah.
So yeah, I pushed to estrone.
Yes. Okay. So here's the numbers. Normally we would see that like below 30 and in the teens in somebody menopausal, right?
Yeah.
And even in a woman cycling on a normal basis, it's going to, roughly average out around 60. It'll peak around 200 as estrogen comes up during ovulation, you know. And so an estrone level in 188 or 409 is a sort of identifier of like, hey, I make a lot of that first step of estrone, right?
Mhm.
The problem is if we don't have an estrone sulfate, right? If we don't have that, we don't know how much of it you get into the water soluble form that you can excrete. And that one was the one you didn't have. So what we don't know is when it was 409, was your estrone sulfate like low? Because that would
Right.
indicate you were unable to get rid of it. It was not the 4-hydroxy one. It was not the 16 alpha hydroxy. It was estrone on its own that was unable to get out.
Okay. And that would make sense because for the diagnostics, it started off with atypical hyperplasia,
Yep.
and it was at the time, and I don't know how much this plays into the direct correlation of the estrone, but it was an estrogen positive receptor cancer that was found on the biopsy in April, where those atypical cells basically flipped a switch and now we're actually picking up cancerous cells. And then they take those cancerous cells and they do further testing on them
Yep.
and to see, what does this look like? So it's a stage 1 estrogen positive, and it does have a genetic mutation that is not full blown Lynch syndrome, but that does show, kind of back to what you said about some genes not being able to properly detoxify or
Mhm.
properly repair. So
Yep.
I do have some repair mechanisms that are damaged on my DNA where my body can't actually see that a cell is damaged and go out and fix it up. It just kind of leaves it as a damaged cell,
Yeah.
thus turning into cancer.
Yeah. Yeah, and I think, because people don't understand that whether it's so Lynch syndrome is a set of genes that clean up and repair and tell cells to die. They're like, "You no longer function, get out of here."
Mhm.
And that doesn't work. And so you usually see a host of cancer risk in that family. And same thing with BRCA. People think BRCA has to do with estrogen. I'm like, it doesn't have a damn thing to do with estrogen. It has everything to do with a cleanup gene that is broken and can't clean up, you know.
Yeah.
And so, what we could extrapolate from that is and we could never really know for sure. Like I can't say this is absolutely what happened, but we can extrapolate from the data we have. You had sulfate metabolites stuck in the body. You were taking what we would have seen or assumed to be adequate levels of progesterone because you were on quite a bit,
Right.
you know.
Right.
But in that rhythmic dose, maybe it wasn't enough because you weren't able to clear the metabolites properly. And then because your cell cleanup genes aren't as efficient as they could be, it wasn't able to get rid of, those early cells that were kind of mutating as they go.
So the fact that I was not bleeding on rhythmic dosing would absolutely tie back to possibly not enough progesterone to produce that shedding of the uterine lining. And maybe it wouldn't have even mattered. I could have gone up, 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 up in the progesterone. But if my body literally can't get rid of the estrone, I don't know that that would necessarily have mattered.
Yeah. Yeah. I mean, it was unique that you didn't necessarily have any breakthrough bleeding despite having that. Because you would expect it. And the truth is, you may have had plenty of a physiological dose of progesterone to manage the dose of estradiol you were on. So one of your other questions to me yesterday was, how do I feel about biased and
Yeah.
estradiol? Because they're again, we have to look at the entirety of the pathways and what really happens in the body.
Right.
You know,
Yeah. So that is the next question then. Based on what you see in the Dutch and the information that we now have,
Mhm.
what would the hormonal protocol be for someone like myself?
Yeah. So here's where it gets interesting. So um, on all our cells, particularly breast cells and uterine cells, we have estrogen receptors, and we actually have estrogen receptors on every cell other than two in the body. And there's two types of receptors. There's estrogen receptor A and estrogen receptor B. And they both do things, right? So like both of them help stimulate bone growth by stimulating osteoblasts and decreasing osteoclasts. They both stimulate, the estrogen kind of activities in cells. However, estrogen receptor A, if it is overly amplified, it's cancer prolific. Right? Because everybody says, well, estrogen is dangerous, it'll kill us. And I'm like, then why do we use a synthetic estrogen called tamoxifen to treat breast cancer?
And you know what? Most people do not realize that tamoxifen is an estrogen. They
It
think
is.
that they were told that it's an estrogen blocker, but it is an estrogen being used in
It's a
tamoxifen.
Yeah.
Yeah.
Yeah, it basically binds to estrogen receptor B strongly and never breaks the bind, right? Kind of like your ethyl estradiol that's used in birth control binds irreversibly, right? So it binds irreversibly. So here's the thing. So your estrogens all bind to these two receptors slightly differently, right? So estradiol has the most protective binding, right? Now estrone, guess what it likes to hang on to the most?
Hmm.
Estrogen receptor A.
Okay.
Right. So cancer proliferative, it has a negative, you want some, but you don't want think of it as a seesaw. I don't want most of it going there.
Right.
So estradiol, if it has the capacity to also hit that receptor and also get made into estrone, if I do estradiol alone, I might be overstimulating. Again, this is extrapolating from the research. I might be overstimulating that estrogen receptor A receptor. Now, estriol, which is a much weaker estrogen, binds almost exclusively to estrogen receptor B, and it's protective.
Mhm.
So I know a lot of people out there are like, because we look at things in this very isolated mechanism. Estradiol is the physiological thing that makes us have all the beautiful stuff like good skin and all the wonderful things of still being a cycling woman. So we just need estradiol because that's the physiological equivalent to the most important hormone. But I'm like, but it's not alone for a reason, right? It's not alone for a reason. If I also put in estriol, right? Estriol is a one-way route. It goes through that CYP3A4 pathway. So, so if I make it, it's that pathway. It doesn't go backwards, so it never gets made into estrone. And if I give a little bit of estriol, I get a preferential tapping on that estrogen receptor B that is making sure that I'm not taking estradiol and making estrone and possibly overstimulating the estrogen receptor A, right? This is me extrapolating from the data. We don't study this stuff because none of the drugs work that way, right?
Right.
I just loved, I had a really heated conversation with the ex-president of the Menopause Society about these pathways. And she said really hot to me, we believe in evidence-based medicine. And I said, what, you mean placebo-controlled double-blind studies? Yes.
Right.
And I go, well, no, nobody's going to produce a drug here because all the drugs mess up these pathways.
Yeah.
And I said, so you're willing to let millennials and Gen X women die from something that we absolutely know is true, that these hormone pathways, whether stimulated with bioidentical hormones or hormones at all, are damaging, but you're not willing to even possibly contribute to the research because you want a drug trial. And she's like, well, we just do evidence-based medicine. And I was like, okay, I had an opinion about you and I thought I was right. You just confirmed it. Thank you.
Yeah, that's just the answer on repeat. She doesn't even know how to reply.
Yeah, I was like, you don't even, yeah, I was like, there is evidence actually. There's a lot of evidence that SOLT1A1 is associated with breast cancer. Several studies coming out of China, right? Because there's a lot of mutations in the Chinese population on SOLT1A1,
So the bias debate is really huge and amongst our and it's amongst people that I very much love and respect. And
Oh, yeah.
I will hear opinions on both sides that bias. You got to add in that estriol to have that protection. Dr. Lindsay Berkson, I absolutely love her. Felice Kirsch, I love her. But then on the other side, you will have oncologists like Julie Taguchi, who I love her as well. And I've been consulting with her as well since my diagnosis, going, you know what, I think you'll be okay with just estradiol. It's confusing out there for us, let alone for the average woman, to make the decision as to which route she wants to go. Now, my whole thought on this, and I'm going to give this to you and you can unpack it. And you said this to me yesterday in a message. With estradiol and estriol, it doesn't have to be 80-20. It doesn't have to be 80% estriol, 20% estradiol. We can compound that to give you that little bit of estriol because maybe, God knows, maybe it's providing some protection based on the literature, but I'll still have the estradiol coming in. So that's, I think, sounding really good to me.
Mhm.
And so based on what you see in my Dutch, what percentage would you do, and what is your opinion on that idea?
Yeah. So yes, I mean, if you look at, because again, they're looking at the way we study stuff in the United States in particular, but in all of science, is a very reductionist way. We go, okay, we got this one this one little variable that we want to look at in this one intervention. And we ignore everything around it, despite the fact the body never is a one-for-one relationship. So, yes, if you look at estradiol, it has the most research showing efficacy, protection, and all that stuff. And like your oncologist said, it has also the most protective studies for use vaginally, or being safe and okay. But like you said, we have medicine 3.0 today, where we get genetics, where we can get hormone metabolites. Like, I would run a Dutch test, run estrone and estrone sulfate at the same time, because then I have
Yeah.
all the data right there at the best level I could, right?
Mhm.
Because then I would see it pretty clearly, and that would say, okay, yeah, this person is a candidate for biased. And standard disclaimer, I happen to be a nutrition professional and a researcher. I don't prescribe, which makes it great for me, because I can look at this very, very scientifically, because I don't have any vested interest in what I say. So the reality is we have the ability to look at that data, right? So
Mhm.
in your case, I'm going to throw your genetics back up here, because I think it's on here. Yeah. Well, let me see. Yep. 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 So here, let me share my screen. So in your genetics, this is where it becomes important, right? So we know that you have a preference for estrone, right? We know you have a preference for aromatization from androstenedione and testosterone to make estrogens. So you're estrogen dominant, and you got more estrogen toxicity. But your
Mhm.
CYP3A4 is slow, right? It is a slow enzyme, which means you're making less of the 16 hydroxy. And everybody goes, cool. That's also cancer proliferative. So it proliferates where 4 hydroxy increases DNA damage. The problem is it goes from there to make estriol. So
Mhm.
you don't have a natural propensity to make estriol out of that byproduct, right? So the first thing I look at and go, okay, I see sort of the sulfate pathway over amplified. If you were to get a bias that has estradiol in a physiological dose and some estriol to preferentially hit that estrogen receptor 2B, that B receptor, I'm still going to get physiological support, but I'm going to make sure that I hit that estrogen B receptor a little harder. And you
Yep.
might be more of like a 50-50 biased instead of an 80-20,
Mhm. Yeah.
instead of
Well,
an
that's my
80-20.
thought is like, why can't we all just get along and find a middle ground? Like, that just makes sense to me, is like
Yeah.
throwing in a little bit of the estriol. Why not?
Yeah.
And you're still getting the physiological doses of the estradiol for the benefit.
Right, exactly. And this is where testing comes in. And it's why in my clinic we've done testing. And it's why on the Minerva project, our telemedicine company, we test all of this. And, it's funny, I'll sit down with our medical group, and they're like, do we have to have that? And I was like, yes. We have to have all of that. We have to see all of that, you know.
Yeah. Yeah. Beautiful. Now, what else do you see on a Dutch that you really like to look at that is beneficial to the listener, so that they know, oh, if they've never had a Dutch test done before, what else it's showing us outside of just those dials?
Yeah. All right. So let me throw this up there. Okay. All right. So obviously the dials are a great just visual view of what's going on. So
Mhm.
again, I kind of talked a little bit about this, but like I said, I was very surprised that you don't experience hair loss, because most women, we have to be very careful of their testosterone dosing, because they will overproduce, your go down your 5 alpha reductase pathway, which is right here, and
Yeah.
make a lot of DHT, right, which is the little
Yeah.
barometer right here, which often results in androgenic hair loss, right? So, hair loss on the head, chin hairs, mustache, peach fuzz.
Yeah.
You happen to be very lucky there. Mine, even if it's in the middle, I'll start losing hair.
Well, here's my theory. I've had this for a couple of years now because I do have elevated DHT. My
Mhm.
hair will go through thinning process. My SHBG is high and it
Mhm.
preferentiates DHT first, that I
Yeah.
have my SHBG binding to my DHT saving me.
Okay, yeah, that's probably true because my SHBG is never high. And for everybody that's listening, SHBG is, think of that as the taxi cab that drives your testosterone and dihydrotestosterone and estrogen around. And if
Yep.
it has low binding, it's going to leave a lot of DHT, more hair loss. And if it's got
Yep.
high binding, it'll kind of attach to it. Right. So I always look at that, and I look at that just because I like to catch that before it starts happening, because when you start a shed, it's very difficult. Also, your progesterone, right? So if we look at the other thing is I look at the relative ratio between your progesterone to estradiol, right? Based on looking at this, you probably still need more progesterone, right?
Mm-hmm. Yeah.
Because I always think of the speed dials need to be going the same direction. Right now,
Yeah.
you make a lot of the alpha pregnitidol, which has the most relaxing effect of progesterone, which is, sort of relaxes you and gives you sort of that GABA effect, which is
Mm-hmm.
positive. Your overall, when we look at your Dutch test, you got this, and you're probably like, rock on. I don't have a problem detoxing.
Right.
Because
Exactly.
the first phase 1 and half of phase 2 looked fine, because your pie chart looks great here, right? You had a lot going through your 2-hydroxy pathway, which is considered protective, although it does have a little bit of extra risk for osteoporosis and somebody not doing all the things like weight training and all those other things. You have a preference for 4-hydroxy, but it's not wildly high. And again, that 16-hydroxy is low because you have a slow enzyme, which means you make a lot less estriol. Right?
Now,
Relative.
if someone does push down the 16 or the 4-OH pathway, on my last Dutch test, the 4-OH was a bigger piece of the pie chart, and I was pushing down that more. So I incorporated in an acetylcysteine, calcium D-glucarate, DIM here and there, indole 3-carbinol, psyllium husk here and there, and that seemed to have brought that red down a little bit. Is that what you would tell a woman who does tend to push down those pathways?
So that's really, really interesting. So I'm going to bring up, I love these questions. Everybody's probably like, why is she grinning like a madman? It's like, because I am. Okay. So I'm going to bring back up this picture because I think it does a better job of that. So your
Sorry, I
DIM.
totally derailed you from the Dutch, but we'll get
That's
back.
okay. No, I do ADD.
Yeah.
All right. Okay. So DIM, indole 3-carbinol, your things like calcium D-glucarate,
Mhm.
all reduce circulating levels of estradiol. So
Okay.
we have to be careful not to do too much of that, because a lot of times people will superdose that and their E2 is low and they're like, why? And then they keep raising the dose. I'm like, quit making it go down that pathway. Right.
Yeah.
And then if you do calcium D-glucarate, it helps make it get out of the stool. Right. So it moves all the estradiol pathway, but it doesn't really move the sulfate pathway very much.
Okay.
Right. So all the things you see right here. So cruciferous berries, indole 3-carbinol, DIM, soy, genistein, flaxseed, caffeine, rosemary. It also affects your thyroid hormone. So we could even get into that wild game. All of those things will improve basically 2-hydroxy pathway and push it a little bit towards that. Now, the 4-hydroxy are more affected by the citrus bioflavonoids like grapefruit, and the citrus bioflavonoids. Hops is actually a really good thing here. The catechins.
Mhm.
Also, your curcumin is actually somewhat favorable here too, but they don't help you sulfate. So the other thing that I often see when we look at the Dutch, right, when we look at these pathways, regardless of which ones we're looking at, is everybody sort of starts at the top of the pyramid, right? I'm going to start with phase 1 detox, and then I'm going to make sure I methylate, and I'm going to take some glutathione.
Uh-huh.
But remember, you got all the trash out of your attic, you got it all out of your closets, but your garage door is empty. You can't get it to the dumpster. And that is the ultimate problem. So you have to go to the dumpster first. Now, salt is dependent on sulfate opportunities, sulfur metabolism. So things like MSM, NAC, B6, your Epsom salt baths is sulfate, right? I need to have sulfate there and available so I can then take that dumpster and open it up and raise the garage door. So when you work on detoxification, you start at the end and work your way backwards. So I would put in sulfate donors first. I'd say, okay, do some magnesium salt, foot baths, do some Epsom salt baths if you want. Take MSM, take NAC, take a significant amount of B6 because it gets chewed up in this pathway.
Mhm.
Molybdenum is also really important. Molybdenum is the door opener for SUOX to allow sulfates to be available. I would get those things in first. Then I would go to citrus bioflavonoids, hops, maybe a little bit of DIM and calcium deglucarate because that's a nice combo. Like I have combos that have a little bit of all these things in it to sort of help all the pathways.
Yeah.
And then I would worry about things above stream, right? Because I think what was happening is you got like everything to the garage door, but the garage door was closed and your garage was getting full of trash.
Yeah. Yeah. Just can't get it to the dumpster. Okay.
Yeah. Yeah, exactly.
Totally
Exactly.
makes sense.
Yeah. And what's really crazy, here's the other thing is that same salt pathway, right, affects thyroid metabolism. It affects testosterone metabolism. It affects catecholamine clearance. So, and because catecholamines go through glucuronidation and also sulfation, right? So often where these things are happening, it's not exclusive to the estrogen. It's everywhere. It's
Yeah.
everywhere.
Yeah. No, that makes sense. Okay. So let's flip back to the Dutch, keep going
Yep.
with that. Hit on
Yeah.
a couple of the other pieces of information that we receive when we do a Dutch test.
All right. All right. So, yes. So we do the Dutch test. Here we go. All right. So if we do the Dutch test, all right. So that's what we look at, right? So on this page, we're really looking at the relative ratio between progesterone and estradiol in particular, and then all the estrogens, whether testosterone is adequate when somebody's on it,
Right.
or that we have an amplification here because that could be a sign sulfation is wrong. And then these early metabolites. And again, yours look really clean, right? And you're actually kind of maybe a little bit over methylated here.
Mhm.
You can also look at some of the, oh, I'm sorry, wrong direction. I will often look also at like what's the total DHT because it's not on the diagram.
Mhm.
Um, you know, and then again the 5-alpha reductase pathway. And then I always look at the adrenal situation too because a lot of people, yours actually looks really good overall. But
Okay.
a lot of women, when they're in the kind of menopause or perimenopausal state, they've got an amplification of metabolized cortisol, right? Which is what we see up in this quadrant right here. You don't. But what we know is when that metabolized cortisol starts to get in that 6,500 range, that will block metabolites and activities of the thyroid receptor.
Yep.
And so
Yep.
that's super common. Your actual rhythm here is a little bit low from a cortisol standpoint. Like
It
you should,
is. It kind of surprised me because I don't feel that.
yeah.
So
It's interesting because it could have reflected that day, right? Like maybe that wasn't super stressful. Because most of the time they would say, oh, you probably need cortisol. But I would say your metabolized cortisol is adequate. So I would say it was more reflective of that day. Um, you know, but this pattern outside of that low range in the middle of the day looks fine. You have compensatory mechanism that looks normal.
Mhm.
I don't necessarily ascribe to if somebody feels fine and they're low here, that may actually reflect. I don't know. I also think as entrepreneurs, you get anesthetized to the stress response. And you just, you're
You
like,
do.
yeah, you've had it for so long, the body's like, got it. I'm cool.
You do. Well, even when I was talking with Cash on my DNA, he was going over the brain component and he's like, you really are a warrior, not a worrier. You have the warrior gene. You run on adrenaline, you run on cortisol, and you probably don't even feel it, do you? I go, no, I'm totally fine. I'm good.
Yeah. You
Yeah.
and me both.
Yeah,
You and me both.
exactly.
My
I knew
brain's
you
like,
would get
got
that.
it.
Yeah.
Cool.
We probably have very similar DNA profiles. So yeah.
Yeah, I would say that stuff is probably, I haven't looked at all of yours. Yeah. So this pattern, now if you were dragging, right? So this would be a
Yeah.
place, if you were dragging here, if you were really like, no, I feel really, really tired, medically, that might be like Cortef, right? Low dose
Mhm.
cortisol, or even things like licorice root short term can help metabolize, and even maybe some adrenal glandular, right? In
Yeah.
the middle of the day to sort of help that boost over a couple months. But
Yep.
sometimes I call it the retirement pattern because I see these women that are finally retired and like the kids are gone and nobody's bugging them and they're starting to live their best life and they're always really low. And I'm like, I think this just reflects the body finally going, thank God.
I guess I'm far from retirement, but I'm just
I
gonna
know
roll
you
with
are.
it because I feel good. It always goes back to how do you feel?
Right.
And whether we're looking at blood, the Dutch, any test, if you don't feel what that's showing, we're not gonna overcompensate and treat that because we don't want to throw you to the other direction.
Right. Yeah. You have to use it all together. It's a practice of medicine, not the absolute of medicine.
Mhm.
And so what's interesting here is we saw your methylation marker, right? So your methylation marker, your for COMT was high, right?
Mhm. Yep.
However, methylmalonate or methylmalonic acid is a little bit higher than expected, which usually means B12 might be slightly insufficient,
Yeah. Yeah.
and probably hydroxy B12.
Mhm.
Your B6 marker actually looked pretty good, but I would say with the potential sulfation problem, I would probably support that anyway.
Yep.
And all your other metabolites here are in range. Your melatonin. Oh, here's another good one, right? So what do we
Mhm.
see here? 6 hydroxy melatonin sulfate
Yeah.
above range. Check that. Now do you take melatonin?
I do.
Okay.
Yep.
We're going to see this really crazy high result if somebody's taking melatonin, but this is a sulfated melatonin.
Okay.
Again, kind of pointing to, hey, there's a sulfate thing going on.
Okay. Interesting.
Yeah. Yeah. So that's how I would look at the overall report. And it
Mhm.
overall, especially reflects kind of your DNA as a whole, but you had some support in there for like DIM and indole 3-carbinol and all those other metabolites to help the 2-hydroxy pathway look cleaner.
Yes. Okay. That makes sense. So really, I mean, this has been eye-opening to me. I will fully admit that years ago, I kind of poo-pooed the Dutch test. And I know there's still a lot of controversy out there on just like biased and estradiol. You have practitioners out there that's like, the Dutch test worthless. And then people that use it all the time. So my view has definitely changed over the years on the value of the Dutch test. And
Mhm.
did I freeze?
Just a little bit, yeah.
Okay, I might have froze. Okay, so let me go back. So no, my view of the Dutch test has definitely changed throughout the years. I no longer poo-poo it. I don't look at it sideways. I look at it as a valuable piece of information.
Mhm.
And honestly, my opinion has changed as well in that every woman, whether you're on static dosing, but especially if you're on a higher dosing or a rhythmic dosing, you gotta have this done, like,
Mhm.
once a year, maybe twice a year, you gotta have it done and just get that information. Yes, it will change a little bit. Like I said, my last Dutch from 2022 looks very, very similar to this one.
Mhm.
However, I have reduced, pushing down that 4-OH pathway through the interventions that I've implemented. But would you say you want to see a Dutch on a woman at least once a year, if not twice?
Yeah, I mean, we do. Here's the thing is 24-hour urine, right? A 24-hour urine capture, that has been kind of a gold standard of free levels for a long time, but not everybody wants to do a 24-hour urine. And we do that as well, when we're really looking. The Dutch test has made it easier by having or the Hue map or the Vibrant hormone zoomer. They're all the same, right?
Mhm.
And I've looked at all of them. I've consulted with Vibrant about the construction of theirs. Um, they have some drawbacks, right? You're getting a single measure onto a basically a lab paper that then gets hydrolyzed and they have to pull things out. So there could be some variability there. And all of them lack some of this deeper dive into just that last kind of step of what biotransformation really looks like. And the reality is even if we're not talking about hormones, these same pathways metabolize drugs like lipid lowering drugs, pain
Mhm.
medications, SSRIs, like all of these pathways metabolize a ton of stuff. And so they all have, I would say they have their credit and their limitations. So I think all of those have at least some of the best stuff we can look at today. You know, I really honestly, this could be done with liquid chromography, mass spec with frozen samples of urine in a single morning study. If you just wanted to see the hormone metabolites, maybe you're not looking for that diurnal cortisol where they haven't gone through that reagent activity. It's just hard to get people in the lab world to think differently because they're just thinking about competing with each other.
Yeah. Yeah. Yeah, exactly. And nobody wants to take that extra step. And to your point about the 24-hour urine, yeah, it's a pain in the ass and it's more expensive.
Yep.
So when you're looking at your average person and what they can do in a day, the Dutch test is
Yeah.
really good and gives us a lot of information and stays within an affordable realm as well.
Yeah, and we generally get blood work around the same time, so we can
Yeah.
see some comparison things. Like I'd want the estrone and the estrone sulfate. And so if we have all of that and then we know how you're metabolizing it, then we're like, okay, we can make some modifications, and you want to look at it again to see if the modifications that you made are working, because that helps tailor your prescription to what you really need.
Well, and just a clarification too, you don't dose based on the Dutch test. You always want to know that level in the blood.
Right.
But the Dutch tells us how you are methylating your hormones, metabolizing your hormones, not necessarily the dosing of your hormonal protocol right now.
Right. Right. Yeah. The gold standard today is still blood levels in blood, recognizing that we can't tell the difference between a free hormone and a bound hormone, but it at least is sort of the standard of where we look at, along with symptoms and other data to identify, yes, this is the right pathway, you know.
Yeah.
And yeah. And so I think it's all part of a bigger picture, because then you could back up and go, well, what's going on with your gut health? And are you hydrated? Do you drink alcohol every day that trashes these pathways? Like there's so many, you have medications that go through these pathways. That CYP3A4, that metabolizes a ton of stuff,
Mm-hmm.
you
Yeah.
know?
Yeah. So just more data on your body to go a little bit deeper and to get more precise with whatever you're doing.
Right. Right. And so as you look at kind of your future and what you choose to do after your surgery, you could look at it and go, okay, yes, biased is probably a better route at a whatever level your doctor would prescribe, just so you could raise that estriol, so get to more estrogen receptor B binding, whether you
Mm-hmm.
choose to do static or some rhythmic dose. I would say if you're rhythmic dosing, I would probably rhythmic dose progesterone at a much higher level,
Yeah.
just to sort of counterbalance it. Although you don't have your uterus anymore, I think it's just still sort of protective.
Oh yeah, I mean it's protected, and that, oh gosh, yeah. Let's just touch on that false premise that docs like to throw out. Oh, you don't have a uterus, you don't need progesterone. Progesterone does so much, from
Yeah.
protection of our bones, to protection of our breasts, to being anti-prolific, to
Yeah.
helping with T4 to T3 conversion and insulin resistance and insomnia and mood. My God, why wouldn't we all be on
Yeah.
progesterone, whether you have a uterus or not?
Yeah. And that's my argument for estriol. Like you don't ignore progesterone like it's like not magically necessary. Same thing with estriol. It's there for a reason. And
Yeah.
just because we haven't studied it heavily doesn't mean it's not there for a reason.
Yeah. I love it. I
Yeah.
love it. Well, Betty, you're amazing. You're so brilliant. You're so amazing. You're taking time on a Sunday to review my Dutch test. And we did all this live. I knew nothing until I sat down with you, except my knowledge of the Dutch. But I wanted, just like we can't think for ourselves, I don't want to have to sit and try to interpret my own Dutch. I want to sit back and have somebody else do it, because that's the beauty of having a practitioner look at your Dutch test. So
Yeah.
thank you so much for unpacking this and sharing this experience with me as I share it to my audience. And I will continue going down these rabbit holes. I've gone down so many that I'm going to be sharing that journey with my audience as well. But thank you for being a part of it.
Absolutely. Thank you for having me. And I think for the people that are listening to this, go and watch it on screen. There's no way to like understand all of this conversation without having the visuals. It's just we need pictures.
Yeah,
So if you're listening to it and you're like, well, I don't know what the hell just happened, go take some time, watch it on YouTube, because that
yep,
will be very, very helpful at helping you understand what we just kind of went through.
exactly. Exactly. Well, amazing, Betty. Thank you once
Amazing.
again for your time today. Love it.
I love it. I love it. Thank you, everybody.